How do we stage gastroesophageal cancer? In this video, we are going to go through the steps taken to get an accurate stage of a gastroesophageal cancer. In previous videos, we discussed the three main subtypes of gastroesophageal cancer: esophageal squamous cell, esophagogastric junction adenocarcinoma, and gastric non-cardia adenocarcinoma. We went through the different causes, who's at risk for each of these. We talked about the different symptoms and the ultimate diagnosis. Now we're going to build on that to discuss how we stage the cancer. In order to do so, first we need to revisit the figure that was shown in the what and where is cancer from a cross section of the stomach wall, blown up in this figure here. And what we see is from the inner side of the stomach or esophagus to the outer side, there are a number of layers, like an onion, that have given names by the pathologist. When there is a cancer, the cancer starts in the most inner layer called the epithelium. Initially, it will be called a tumor in situ with high-grade dysplasia. That's not invasive. But over time, the cancer cells will start to invade downwards or outwards from the inner layer into the deeper layers. So first, you'll have a T1 lesion, then T2, T3, T4A, T4B, through the different layers of the wall of the esophagus and stomach. The T stage refers to the tumor stage, or how far into the wall of the esophagus or stomach the cancer is invaded. It's important to note that in this staging system, it is not important to know the size of the mass. The mass can be very large but superficial. It would be a lower T stage. It can be very small but very deep, and it would be a higher T stage. Important things to note. The next part of the TNM staging that's important to understand is the nodal staging, or the end stage. And what this is telling us is how many regional lymph nodes nearby the actual primary tumor are involved with cancer or not. And finally, there's the M stage, whether or not there's distant metastatic disease or not to various organs that we had gone through, including the liver, a commonplace, or far away distant lymph nodes are called M1 lymph nodes. With that information of the T, N, and M, we can come to a final stage. And so you can see from this table that the higher the T stage, the higher the actual stage, stage 1 to stage 3. The higher the nodal stage, the higher the actual stage, stage 1 to stage 3. And of course, the higher the T and N together, the higher the stage. There's a few notes to be made here. The first is that in some subsets of gastroesophageal cancer, the adenocarcinomas and even the squamous cell, the grade of the tumor, which we went through in the how do we diagnose cancer, the pathologist will tell us a grade or a differentiation of the tumor cells. Are they well differentiated, or are they poorly differentiated, or moderate in between? And this will have implications on the staging. The higher the grade, or the more poorly differentiated, the higher the stage. Secondly, an important aspect is that if there is distance spread to anywhere in the body outside of the regional location, or what would be referred to as the surgical field, irrespective of what the T stage or the N stage is, it would be called M1 or metastatic. So examples could be, you can have a relatively localized cancer in the primary tumor, T1, N0 or N1, but if there's metastatic disease, it still equals stage 4 disease. Conversely, if you have a very locally advanced cancer, T4, N3, the highest T stage, the highest N stage, and metastatic disease, then it's stage 4 disease. So stage 4 sites trump what's going on in the T stage and N stage. There are tables that pathologists would then go to really give us what the final stages are. The top part is showing you what the T stage is, and it's the definition is which layer the tumor invades to. The N stage, how many lymph nodes are involved, and whether or not there's metastatic disease. And then based on the T, N, and M staging, you can get a stage from 0 to stage 4 based on these characteristics. And the same is true, this is for gastric cancer, the same is true for esophagogastric junction adenocarcinoma with slight differences. And the same is true for esophageal squamous cell with slight differences. So there's 3 different staging systems for those 3 different subsets. In the How Do We Diagnose Cancer video, we went through all of the tools used to come to and pinpoint a diagnosis, namely the endoscopic evaluation with biopsy with EGD. And this was what gave us a pathologic diagnosis, the biopsy. We also talked about CAT scans, PET scans to help with staging to evaluate if there's any distance spread. It is CM here because that's referring to the clinical stage. We haven't invaded or biopsied anything, but we've just evaluated non-invasively with a CT and a PET scan to see if there is or is not spread to distant sites. So that can give us a clinical stage. We also talked about the endoscopic ultrasound, which I'm going to go through a little bit here as well, which is helping to get the clinical stage locally from the the tumor depth and regional lymph nodes. Clinical versus pathological staging is an important thing to understand. Clinical stage, as I just mentioned, is using all of these tools to evaluate the primary tumor in a relatively non-invasive way, i.e. without surgery or deep biopsies. And so the CAT scan and PET scan, as I mentioned, can get whether or not there's metastatic lymph nodes or regional lymph nodes involved. The endoscopic ultrasound I'll take you through will get us the clinical stage. But it's the pathologic stage at the time of surgery when the primary tumor and all the regional lymph nodes are removed, and the pathologist goes through all of that to evaluate what the T stage is and what the PN stage is pathologically. This is the gold standard. These tests are trying to approximate what's going on there. They're not perfect, and sometimes we can do all of these tests, get a certain stage clinically, T and N, and then when we go to surgery, the PT stage and PN stage may be different, and that's because these tests, again, are not 100% perfect. That said, it's the best that we got in this non-invasive setting, and it gives us a framework to work by in terms of what we think the stage is without actually doing the surgery yet. Another thing to note is that when we get to the treatment segments, when we're in the perioperative setting before and or after surgery, treatment given before surgery is called neoadjuvant therapy. And so if we do clinical staging at the time of diagnosis and we get a certain stage, but then we treat with neoadjuvant therapy, chemotherapy typically, we often see shrinkage of the cancer, which is what we would like to see. And so therefore, the T stage and the N stage at the time of surgery do not reflect what the stage was at the time of diagnosis, because there was an interval of treatment in between. And so the pathologist denotes that by saying YPTN, meaning this is the stage after neoadjuvant therapy. And we're going to talk more about that later when we talk about prognosis and perioperative therapies. So if the cancer is looking to be localized and not metastatic based on these clinical tests here, we also, and we'll be talking about at depth throughout many of these videos, that we recommend to do what's called a diagnostic laparoscopy with cytology washings, because despite looking normal on all of these tests, metastatic disease to the peritoneal cavity can be undetected and be below the radar. So we don't see it even though it's there. In order to identify that, a surgical procedure, often just a day procedure, you go, the surgeon places 2 or 3 small incisions and looks inside with a camera to evaluate the inside of your belly cavity, and also sprays fluid inside there and then collects that fluid. This is taken and sent to the pathologist and evaluated to see if there's any cancer cells inside that fluid. Similarly, if they see cancer there, they will biopsy it and send it to the pathologist. Also, if these tests don't definitively identify a metastatic site, but there's maybe a suspicious spot that's not clear, then a biopsy of that spot would be conducted as it was seen on the CT and or PET scan. And that would help to identify the pathologic metastatic sites. So these samples obtained through these tests would be sent to the pathologist and evaluated to determine whether there's peritoneal disease by pathology, cytology positive disease in the fluid, and or a biopsy of a site like the liver or a distant lymph node, and to determine whether or not there's pathologic involvement in those areas. Only then, if there's no definitive evidence of metastatic disease, typically, where a surgery would be conducted in order to remove this cancer with curative intent. In the How Do We Diagnose video, we talked about CT scans and went through them at length. We showed how it would look normal for an esophagus and how an abnormal one would be clear in some cases if it's large enough. And similarly, in different views, we could see a normal esophagus and a abnormal one. I should say that I've taken all of these images just off the internet. Similarly, for stomach cancer, a normal stomach nice and thin versus a mass or the full thickness of the stomach visible to the radiologist, and on the other view, a thickened stomach going up into the G junction. In all of these CT scans I showed you, on the surface, it looks like there's no other disease outside of those of that primary tumor. The liver looks clear, for example, without obvious metastatic disease. So the CT scan is helping to stage whether or not there's metastatic disease there. On the other hand, in other cases at newly diagnosed setting, we have a primary tumor, but then on CAT scan, there's obvious liver metastases. And this would be, by definition, a metastatic stage 4 cancer. In some cases, when the patient presents right away, we have an endoscopic biopsy that confirms there's cancer there, and we have a CAT scan that shows obvious metastatic disease. In that setting, we haven't done specific tests, the endoscopic ultrasound, to obtain what the T and N stage is. But as I was pointing out earlier, if there is metastatic disease, it trumps what's going on in the T and N stage. And often we won't proceed to do the endoscopic ultrasound in that situation. And so we denote that by saying TX, NX. We don't know what the T and N stage is because it wasn't evaluated, but we know there's metastatic disease and we can proceed. We looked at PET scans also helping us with staging, where in this example, we have a distal esophageal G junction cancer that's uptaking on the PET scan, but no obvious metastatic disease elsewhere. So a localized and locally advanced cancer. On the other hand, we showed example where we had distant metastatic lymph nodes. Often these lymph nodes don't look abnormal on a CAT scan, but then a PET scan will show them uptaking, which is showing us concern that there's spread there. And on occasion, if we really want to be confident and sure, we can biopsy this to get a pathologic M stage and be confident that we are dealing with metastatic disease to distant lymph nodes. Similarly, a PET scan at first diagnosis can identify the primary tumor and liver metastases. In both of these latter two examples, again, this would be considered an M1 cancer, stage 4, and often we wouldn't proceed to evaluate the primary tumor with endoscopic ultrasound. But if the CT scan and the PET scans do not show any evidence of obvious metastatic disease, then the next step would be to proceed to do an endoscopic ultrasound to really get a sense of the clinical T and N stage. And remember, this is a specialized endoscopy that has an ultrasound probe on the end of the endoscopic tool, and that can help to evaluate in detail this primary tumor. If we're looking at the esophagus here through a cross section, and this is the middle of the esophagus where food comes through, and this is the actual endoscope, this is the most inner layer of where the cancer would start, and then these are the other layers of the onion going outwards. And so in the setting of where there's a primary tumor that could be evaluated and could be assessed how deep into the wall the mass is growing. And there is some subjectivity to this, and there's some operator dependence, the experience of the gastroenterologist who performs this. And so they will give us a clinical T stage. Similarly, they will assess nearby lymph nodes to see if they look enlarged or abnormal and give us a clinical nodal stage. So these are clinical stages, again, to reiterate, because this is not obtained from a pathologist who's looking under the microscope and actually seeing these layers. This is an indirect estimate or approximation of these stages using this ultrasound probe. So it's not always 100% accurate, but it is usually, depending on the operator, but usually estimating the actual pathological stage. So the next sort of terminology that one needs to understand is that we talk about a localized primary tumor or a locally advanced primary tumor. A localized primary tumor would be very early stage, like a T1, and in my view, a T2. A locally advanced cancer, on the other hand, would be considered a T3 or higher, T3 or T4, no matter what the nodal stage is, or any T, but with a positive lymph node, one or more lymph nodes positive on the endoscopic ultrasound. And for example, you can have a T1 N1, and that would be a locally advanced non-metastatic cancer, as long as it wasn't seen to be metastatic on the CT scans or PET scans. This becomes important because this not only has prognostic indication, but it also will dictate which therapies one is going to consider, whether it's localized, locally advanced, or obviously metastatic. One aspect that will keep recurring through many of the videos is peritoneal disease, because it is quite common with gastroesophageal cancer. And this is an example of a CT scan showing obvious peritoneal disease. And so just to take you through it, there is the liver here. This is a cross section through the abdomen. This is the liver. This is the stomach. And all of this dark gray area shouldn't be here. It's just a collection of fluid that we call ascites. And the arrows on these scans are showing to nodularity that's in there that the radiologist notes and visualizes. And ultimately, these end up being cancer nodules inside the abdominal cavity. And this is called carcinomatosis. So this is an example of a CT scan that's obviously has peritoneal disease at the time of diagnosis. And to be 100% certain, one can drain that fluid with a needle that's placed into this fluid cavity and drained. This has dual purpose. One is to confirm the diagnosis, because that fluid can be sent to the cytologist and they would evaluate it under the microscope and confirm that there's cancer cells in there. And also because this fluid can get high pressure and cause abdominal discomfort and distension, this can be palliative to remove and decompress that fluid. So this is another example. If this was the CT scan at the time of diagnosis, that we would diagnose this as stage 4 gastroesophageal cancer, M1, and we wouldn't need to proceed with an endoscopic ultrasound, and we would leave it as TXNX. So that was an example of where it was obviously spread, and the CT scan picked that up with a non-invasive test. On the other hand, there are a number of cases that have CT scans, PET scans, and the endoscopic ultrasound that suggest merely a locally advanced cancer that is not obviously metastatic. And that an example of that would be a clinically staged T3N1 MX. This is probably one of the most common stages for gastroesophageal cancer at the time of presentation. And this, as an example, would be a locally advanced cancer, again, defined as being a T3 or higher NE node status or NET status with at least one node being clinically positive. And so in this situation, it is recommended certainly for gastric and G-junction cancers, but even for distal esophageal adenocarcinomas, that a diagnostic laparoscopy performed and to evaluate for the presence of occult peritoneal spread or silent, under the radar, not visualized on the first pass of staging analyses. And if the surgeon, upon entering the abdominal cavity, identifies nodules which look like white plaques with or without any fluid collection or ascites, this would be, again, called carcinomatosis and would be biopsied and consistent with metastatic spread there. Conversely, if there is fluid there with cancer cells floating inside the fluid, with or without the visualization of peritoneal nodules, this also would be considered stage 4 and spread there. So an example on this schematic cartoon is within the belly cavity. As the surgeon, this is a full open incision. They would be using small holes and looking with a camera for a diagnostic laparoscopy, as I mentioned earlier. But each of those little white spots that you see there throughout this abdomen, in this case, there's diffuse peritoneal spread, would be consistent with carcinomatosis. And this is a real life image from intraoperative laparoscopy through the video scope, showing the various white plaques throughout the abdominal cavity, sitting on the inside of the wall of the abdomen, of the skin, and oftentimes sitting on top of the liver. This is the liver here, and on the bowel. So if peritoneal nodules and or ascites are visualized, again, this is consistent with M1 disease, and that equals stage 4 cancer. Even if there's one nodule versus innumerable nodules, like the examples I've been showing you, would still be considered spread and metastatic disease. It would indicate different burden of disease, maybe different symptoms. One nodule may not be symptomatic, whereas innumerable nodules, and especially if they're large, can be, as we'll talk about in later videos. But either way, they're both considered metastatic M1 disease. Similarly, if you have cytology positive disease in the ascites, when the pathologist cytologist looks at the fluid, this equals metastatic disease, irrespective of whether or not there's any nodules visualized. So why do we stage the cancer? Just a foreshadowing of the next video. The stage impacts prognosis. The lower the stage, the better the overall prognosis compared to higher stages. And as I was also alluding to, the stage also impacts treatment plans. So based on all of these staging procedures, we will funnel into different categories of stage that then have different approaches for therapy that we're going to go through in later videos. So in this video, how do we stage gastroesophageal cancer? We built on what we learned in the how do we diagnose gastroesophageal cancer, as these go hand in hand at the time of diagnosis, with using the endoscopy, the CT scan, PET scan, endoscopic ultrasound if warranted, diagnostic laparoscopy with washings if warranted, to come to a final TNM stage that gives us an overall stage. So stay tuned for the next videos on what does the stage mean in terms of prognosis, and later videos on how we proceed with therapy given the various different stages that one could have. Thank you.